What I want to give you a little bit of time to do is do some strategizing around care coordination in your area. So I have a few options and a feeling about what I think would be most productive, but if you all can give me some input, that would be great. So can I just see a show of hands, who has colleagues from your actual agency present with you today? Oh, okay. Cool, so that's more than I thought. So we have two options with this little chunk of time. So either you can gather with the folks from your team and talk about what's going well and not well and come up with some practical steps around improving care coordination and collaboration in a client-centered way for your agency. Or we can gather folks across agencies in regional clusters, and you can talk together about challenges and strategies for improving care coordination in your region. So my feeling is regional would make more sense, but what do you all want to do? Can I just see a show of hands? If you want to gather in your agency group and talk about challenges and improvements at your site, can you raise your hand?
Yeah, because what about people that are statewide?
I think maybe we'll gather the statewide people as a statewide group. Would that make sense? And how many people would prefer to do a regional cluster? Okay, great. So my Vermont geography is extremely poor. So I know, so if we can talk about what the best way to cluster is there'll be a statewide group, a Burlington group. What else should we do?
Northeast Kingdom.
Northeast? Okay, let me just write this down so I make sure I got it, and then we'll assign a table for each group, and I'll tell you what you will do next. So we have the statewide folks, we have the Burlington area, we have Northeast. Why is it called a kingdom? Does it have a king?
A king and a queen. I'm the queen.
Does it have a castle?
No, I don't, honestly, I don't know.
That's cool. It sounds very quaint. So Northeast, where else should we be?
It was separate from the state. It was two states. Vermont was two states.
Oh, okay.
The Northeast and.
Okay.
So that's why.
So that's three. Where else would folks like to cluster? What's an area? Brattleboro. So for Brattleboro, was there another town that was Springfield? Okay. And how many Rutland area people do we have? Okay, so you can, what would be the right group for you to join?
I guess we'll do Brattleboro.
Okay. Is there, if you're looking at these four groups, is there anyone who's like, wow, I don't belong in any of these groups? Okay, shall we make a Randolph group? Okay. Great. So if we can put statewide at table 1, Burlington at table 2, Northeast Kingdom at table 3, Brattleboro Springfield at table 4, Randolph at table 5, and if you're not sure where you should go, yeah, Maxine? So, okay, so for Randolph, can we call this the central group and include Barry and Montpelier? Is that what you said?
Yeah, it's Central Vermont.
Okay, that's great. So that would be table 5. So what I'm going to ask you to do in a minute is go to the appropriate table. One person will be your scribe, and if you can talk about where you work, what your role is, what your focus is, and then thinking about coming up with some steps around improving collaboration, communication in your area. So at least 3, not magic wand, but realistic things that you can imagine doing for a follow-up. And if you want to spend some time just talking about challenges in your region, that would be helpful as well. Okay? Does anybody have any questions about what we're up to for 10, 15 minutes? Yes?
I mean, the challenge is easy.
I would be really interested in hearing what's really working well in the regions, for sure, afterwards, just as a synopsis. Like, I hear great things about the Rutland area, so I've been wanting to talk a little bit about that, and, I'm sure everybody could talk about it.
So if you have some best practices from your region that you think would be of interest to other parts of the state, if you can just jot those down as well. You know what, I will type this up on a slide so you don't have to remember all of that, and so you can check in on it. Okay, so just arrange yourselves and I will put directions in a more visual way.
And then you can coordinate afterwards.
So I'm happy that you all have had a chance to begin your conversations together. I would like us to check back in. If you can stay at your regional tables while we do the check-in. So I guess let's start with the with table 2, our Burlington group. I think you all are you the biggest group over there? Maybe. So if you can share with us any best practices from your region that you think would be of interest, and then a little bit about what your action steps are, that would be great. Just a reminder, please do not be on your phones at this time. You can step out if you need to step out, but not in here. Go ahead.
One of the things that we did in our area was we moved our learning collaborative right to the hospital. We meet in the emergency room.
Really?
Conference area, because the hospital wasn't coming to the learning collaborative.
Okay.
And
so you went to them.
We went to them, and so now basically it's open door. They can filter in and out as they're available, and apparently we've gotten much more involvement from the hospital staff by doing that.
That's awesome. Brilliant. That's just really smart. Whoever your most overscheduled, resistant members of your team are, go to them. Yay.
I don't know whether I have anything in particular, like in terms of best practice. I think everyone's doing it, but I just, one of the things that I want to mention is I have like colleagues that I work with around this table, and I work for a patient-centered medical home, FQHC, and you know, instead of, you know, with healthcare reform, we are basically trying to branch out as much as possible and really, really trying to branch out into the medical neighborhood instead of just the medical home, and, you know, really pulling in all our collaborative partnerships. You know, we've been actually creating space, and leadership has been very supportive in the past to kind of have meetings in the medical home or elsewhere at the ED as well, to kind of wrap around some of our more vulnerable and more complex patients.
Yes.
Just because it really does take a village. And I think that, you know.
So you're doing active village building.
Yeah, we're doing active village
I
building,
like
and I
that.
think that's really exciting. And I just know it's the case because literally I'm sitting with my colleagues around the table here because we do attend these meetings and we are working collectively.
That's great.
So,
Let me sharing the realistic.
Yes, yeah. So what can you, it sounds like you have a really good foundation in place. What would be the next steps?
Well, I would say that we mostly are frustrated by a lot of things. So the realistic goals are, we talked about a statewide shared care plan, like the one from Care Navigator through One Care, being realistic.
Okay.
We talked about.
Does everybody know what that is? What does that mean? Yeah, okay.
We talked about universal releases for consent to communicate. Seems like it should not be that difficult, and yet it is. And universal forms. For example, at the table we have CVAA and SASH, who both do a different 27-page intake.
Which is so tedious if you're on the receiving end of that.
Yeah. And I guess we do that because it goes back to billing, a little out of my comfort zone here, but each of those organizations have to do that in order to bill.
Okay. So what can you do about that?
Well, universal forms, you know, like some way to figure out that we don't have to keep duplicating these services over and over again.
Okay.
Also for the patient, I mean, you're doing these intense 2-hour-long interviews.
I mean, I know it's a hassle for the staff, but I worry more about patients. You're like, hi, did I just
Yeah.
have this conversation 3 months ago with someone down the street?
And so
that is annoying, and also potentially a care barrier.
yeah,
Because
and if we have a
yeah.
shared care plan, those people in that patient's life are going to be identified in their role.
Yeah.
So we could, if it wasn't back to billing, avoid some of that duplication.
So that would be worth, I mean, it's interesting, I think it's an important point. In the Boston HIV world, the two main funders were the Bureau of Substance Abuse and the State Department of Public Health, and they had separate reporting systems, and they funded almost all the same agencies because one was the city and one was the state. And so people were like, you're wasting our time, you're making our clients crazy. So they came up with joint forms, joint assessments that would satisfy the requirements for both. So it may be something that is a conversation to have with funders as well as among yourselves. This is good. Thank you.
So there's hope.
There is, it's a slow process. You're like, oh my God, how many conversations are we gonna have about, the idea makes sense, why is it hard to implement? Because the systems don't work together, but it can happen.
And our rural nature makes a lot of that more difficult, that human touch, your phone call away, but you're really half an hour for a drive.
Yes, you can just stop in
Yeah.
anytime. Fair enough. So can we hear from our Northeast Kingdom group, table 3? So if someone can tell us any of your best practices that you would like to share, and maybe someone else share your action steps.
Okay, so the team meetings that currently go on once a month, I guess throughout our table, we have come up with some people that actually may come to our meeting
Yay.
to see what it looks like and kind of how we can move forward from there. And this is really us. We kind of, we're getting a lot of information from each other just about what we all do, which is how we spend a lot of our time. But I just want to throw out that for me, I have only been in my job a few weeks.
So you're in the learning curve right now.
So for right now, I'm kind of the patient. And it's kind of where I connect with, because I come from primary care and I come from women's health, that I'm learning a ton, but I also can see and understand and really relate to a patient saying, what are you doing? Who are you? Why are you helping me? And where do you fit in my process? And I think everybody is these groups are incredible and a huge help to someone, but when you don't understand what's going on, so to me, a big thing would be to kind of figure out how to make sure that patients do understand who's on their team and what their roles are and how we can show that they have that. And when patients go from provider to provider, they're supposed to have their med list.
Yeah, like folded up in the wallet, right?
And that's important. Well, it's almost equally as important to know who's on their team. And they don't carry that, and they don't all know who that is. And so, to me, being new, and I'm so sorry if I'm wasting anyone's time, but
No, it's all good.
to me, that's a really big piece that's kind of missing.
Yeah, I mean, I think we sometimes, because we know what we do, we assume that patients also understand, why am I here, what am I doing, how am I different than the other people on the team, and so really making sure that we're taking the time to explain that and to document it. I mean, we have in addition to the kind of fill in the contact information form, we also have a more visual one that just has bubbles with the client at the center and then all the people who are connected, and that has the providers in it. So sometimes it's helpful to carry that and be like, okay, this is the so-and-so and this is what they do,
Yeah.
For sure.
I feel like wanting to throw out an acronym just because I want to fit in, because I do not know all these acronyms I'm hearing. I'm like, what? So I can appreciate when you mentioned that.
Thank you. Anybody else from this table want to share anything about best practices or about action steps for your region?
So I think one of the things that we discovered is turnover in care coordinators for some of us. And Casey was saying that she doesn't know who to go to get resources. So one of the things we offered was which she's doing already, is going back to her other people that she works with, the other nurses and the other care coordinators from SASH, to get the information that she needs, but also designating what her areas are, because she's split between us, St. Johnsbury, and another county. So letting her reach out to us with what we can do with those people, and even we're able to connect as community connection into other areas. We can reach out to other community organizations and help people that are not from our area but seeing some of the providers in our area to get them wrapped. So it might be a help with her. Realistic steps to improve care. I honestly feel that we do such an amazing job, not saying that there's no room for improvement.
But you're feeling pretty good about sort of the status quo right now.
We are. The communication. And one of the things we talked about, too, going back to the patient, is having the team meetings, but bringing the patient in and letting the patient know that this is what I'm, like you were saying, this is what I'm doing, this is what I'm doing, this is what I'm doing. So the patient knows that this one is handling my paperwork, and this one is handling my medication, and this one is handling my mental health. So I think it's important to allow the patient to determine who he wants the lead, but also having that conversation and what can help them.
Got it. Two things I want to just piggyback on that. One is, I think often it is helpful to have the patient at the care
Yes.
meeting.
Yes.
We're used to, I think, for convenience sake, or because there are things that we might say in the meeting that we wouldn't say in front of patients, but I think having them present is a really nice way to build the team and to really be accountable to making sure what you're coming up with is in fact client-centered.
And them understanding, because often we do things and we say things that we think are, and then when you get the patient in there and you ask them, so this is what we thought, what do you think? It's completely different.
Yeah, absolutely. The other thing is, I think it's important when you get invited to do things that are outside your role or outside what you're agreed to actually say no and refer it back to the right person. So we can say, this is your role, this is my role, but if the client comes in crisis and I'm going to start doing your job, it makes things more confusing. So to be comfortable enough to say, I know you need this assistance, this is the person that you need to go to, is part of keeping that clear. So this is good, thank you. Can we talk with Brattleboro Springfield, table 4? So first hearing about best practices and then about your action steps.
Okay, our best practices was in Rutland, there's been a merging of the referral committee with the learning collaborative, and there's, I don't know if it's the direct result, but the coordinated entry point it's just coordinating those activities has turned out to be a terrific best practice of them building networks. Is that key? Yeah. The other one was the initiative called Coordinated Entry. Is that right? Yeah. Oh,
Yeah,
yes.
yeah.
Yeah, hold on. Go ahead. So there's two kind of general efforts that are happening, I think, in the state. One is related to the Learning Collaborative, but then also addressing homelessness. It's called Coordinated Entry.
Okay.
So it's no wrong door to access housing.
I
So
think I
those
saw a little
two,
map of it on
yeah.
one of the state websites.
So it's ensuring that there isn't duplication even in that process. So having our housing representatives join the learning collaborative so that we can learn from one another and implement strategies and also use what's already available, I think is working really, really well in Rutland. Sandy, do you want to talk about the training series that you're doing?
So we're also doing toolkit training quarterly with folks around Rutland. It's for the people who haven't participated in the Learning Collaborative, and one of the benefits, besides learning the toolkit, which is great, but we're not doing it in one organization. We're bringing people from different organizations to a central place and doing it together. And the last time we did it, we had people from drug court, we had from parent-child center, from mental health.
See, a really wide net of people gathered.
And we could hear them all talk, and we talked about it as kind of like speed dating, that they all learn a little bit about each other.
Yeah. Well, and that networking, I mean, you may think it's just like hangout social time, but it really makes a huge difference. Good, go ahead, Laura.
So one of the things too is the Community Health Team Community Resource Guide that in Rutland every year they hire an intern to update the guide every summer.
Yay,
so that
interns.
it's sent out, they take charge of it, it's sent out annually so that it's fresh information, it's not 10-year-old information, 5-year-old information, so that it's really useful. So they make a commitment to doing that, and that's actually proven to be a good initiative that's
great.
had good outcomes. The other
Well, it's
thing,
so practical too, because it's the kind of thing that you put up electronically. Everybody, if they need it, and then there you go.
and then the last thing, which kind of builds on the universal forms and discussion that we had there, is we were discussing how different organizations should also let other organizations know what kind of information they need. So the idea is sort of the way when you refer a patient to a specialist, that you have your, informal and formal referral agreements, having something similar between agencies. It's one thing to have the consent form where the patient's allowing you to release information, but then learning what each organization actually needs so that it becomes actionable information and the information they need. So then, again, it kind of ties into lack of, trying not to have redundant efforts and so on.
This is great. I mean, so I did intakes for our HIV care coordination program, and the referrals mostly came from clinics, but we needed them to send lab work, med lists, a variety of things so that we didn't have to be, gleaned from the client, and the client didn't have to do the running around. So we would get the release form, the one-page info sheet, and then the documentation. It would just come via fax or come electronically from the referrer. And I think that makes things so much simpler for the client if what is needed can be clear. So thank you for that. Yeah, go ahead.
And so we didn't actually talk about this at our table, but one thing that I've been hearing a lot at the various conferences I've been going to is about releases of information and how can we all collaborate and talk to each other without filling out 20 different releases. And one of the things that we did that was really cool, and this helps me every single day, is we have a release that was vetted by our attorneys as an FQHC, also the designated agency attorneys, and a couple of other attorneys for other local agencies or partners in our community. And what the release does is it makes it so that we can all talk to each other. Once it's one form that you fill out, and you can talk to anybody on that form. It designates the type of information you can share on it as well. But it makes it so that we can all talk to each other without having to go through that list and make sure you didn't forget anybody or anything like that. So everybody's listed on that.
That's great.
Release.
So a legally sensible group release.
Yes.
Awesome. Do you all have any action steps? It sounds like you have a lot of best practices.
Just one last thing, because in the Brattleboro Learning Collaborative, St. Johnsbury has been our model, and other places have been our model. And so I just want to, it's encouraging to hear the work that you're doing, that you're a year out from where we're at, so holding on to that, knowing that as we pave this road, it's going to be bumpy, but we're seeing where we're going in this very room.
Some modeling of success over here. Great. So can you pass it to our Central Vermont table here and share some best practices and then some action steps if you have any?
Okay, you want to hear our best practices. So one thing that I was telling these guys that I was told by one of our leaders was that sometimes people won't do the right thing because it's the right thing to do. Or because it's what they're paid to do, but lots of times they will do it if there's something in it for them.
Okay.
So what I've done a couple of things. One was we followed the SASH model because we noticed that had quite a few people had that time carved into their day. The Council on Aging, the VNA, We Care coordinators, and so I got a conference room for right after that, so that people that are non-SASH participants could have meetings there or collaborate. And also we've had a whole lot of things about the records releases, like what they said, but so that people don't have to fill out so many forms and reports afterwards or update the care plans, to try to get them to those meetings. That way they wouldn't have to, because they could just do their verbal report. And also...
So it's incentivizing people to go to meetings by reducing potentially their documentation work if they do.
If you can show them what's in it for them, they may be more apt to do it.
Terrific.
And then also with our mental health agency, they had a couple of good experiences, and so they started putting, instead of when they enroll their clients that they can talk to the primary care provider, which they rarely can, they put primary care team on it, and now that they think that is to include the care coordinators, and they will communicate with us.
That's awesome. So I think that's also a really good example when we think about how you create those collaborations. Usually you make one connection, they try it out. If it goes well, it opens the door for access in a much broader way. So yay. Good. So do you all have any action steps in addition to these successes? And anyone at the table is welcome to.
Well, I think one of the things we talked about is because we're in 3 different areas, so some of the stuff that's working for this team could be an action step for another team.
Okay.
So, connecting the SASH team meeting with the community health team meeting to make sure that there's more participation from the people that are coming in. What else was there? We had a lot to talk about.
We talked about having universal secure email, but it turns out that it's highly expensive, those softwares. So
Okay.
if we could get the state to pay for it, that'd be really good.
This is good. So statewide people as well as state people in the back, take note. Great. Good, good. Laura, did you want to?
I just have a question.
One of the, can someone address this if they know the answer, that with the healthcare navigator, the shared care plan, I thought that one of the challenges with that is that it's not part of the medical record in some cases. Is that true or not, or am I opening up a can of worms we better not deal with?
I actually have no idea, so someone else would have to answer that.
Are you, it's
At Gifford Medical Center, we did have that made into an e-form, so it can be in ours. The other way is if we filled it out by hand or typing, we'd have to have it scanned in.
Okay, so there are some different options site by site as to how to integrate that into the medical record.
Well, it's also going to be in when.
Go ahead.
So that's also going to be when we are all on Care Navigator in the bright and distant future. I mean, recent, soon. Who knows when? But anyway, yes, it's coming.
Good. Yeah, great. So thank you folks for being willing to put your heads together. If folks have cards, I know some of you already work together, but this would be a nice moment to exchange contact information if it makes sense for you to be in communication with each other if you don't already have it. And I'm just going to do a little time check here. So can I just also get a pulse of the room? So I feel like rather than starting another activity, we should take our lunch break now. Does that seem right?
Yes.
Yeah. It's a little bit early, earlier than planned, but it just means we'll have a slightly longer afternoon, but I think this is the right time to stop. So it's 12. So if we can be back and ready to go at 1:15, that is the plan.